morning. My name is Gustavo Santo. I'm a neurologist in Centro Hospitalar Universitário de Coimbra, Portugal, Europe. And I was invited to share preliminary data from South America, the AD2 cohort. And it really is an honor to join this great conference and to share this data with you. We tried to get in touch with different physicians from different countries all around South America. It was not easy, but we tried to. We performed a survey in order to have a better understanding of the different aspects of this rare disease. The survey was able to be fulfilled during the most part of October 2020. And as you can see, most of the answers came mainly from Brazil, but also from Argentina, Chile, and Venezuela. And Brazil also reported most part of the patients so far. The prevalence of DADA2 is really unknown, but its distribution around the globe is probably heterogeneous based on allele frequencies of in silico predicted ADA2 damaging variants. The estimated prevalence is or might be as high as 4 per 100,000 people. We know that in specific areas there is a high prevalence of specific mutations, just like in the Middle East or in the north of Europe. The data we obtained from South America is really far from those values, but we have to take in mind that this is a rare disease, has been described recently, so it is probably under-recognized. Regarding the specialties that deal with these patients, we became a little bit surprised considering the pleiotropic presentations of disease, just 3 specialties in children and 1 in now adults, rheumatology. The prevalence of different phenotypes are similar to the majority of cohorts that have been described, include the neurologic manifestations of disease. As you can see, stroke is in the first line, particularly mainly ischemic stroke, but also hemorrhagic and cerebroconoid hemorrhage, and other features of vasculitis like polyneuropathy or cranial nerve palsy. Patients being followed are almost all homozygous, but I would also like to address that a small percentage are or seems to be symptomatic heterozygous. Considering diagnostic test, genetic testing is the first-line diagnostic approach, and plasma ADA2 activity is seems to be clearly underused because it is not available. It's not available in majority of centers and even in the majority of countries. This is in contrast with some protocols like just we have here in Portugal. That is, if you have a clinical suspicion, you perform first ADA2 activity in plasma, and if it is in the heterozygous or homozygous range, then we perform genetic testing. Patients with the vasculitic DAD2 phenotype are treated mainly with anti-TNF alpha, alone or combined with other immunosuppressors. And in the hematological phenotype, we see a more heterogeneous therapeutical approach, with bone marrow transplantation being considered in half of the patients. In summary, this is the first picture of DAD2 in South America. data from this survey suggests a lower prevalence than in other parts of the globe, but this is probably under-recognized, as we said first. Clinical presentation phenotype is similar to other main known cohorts. There's a small number of specialties dealing with the patients. In diagnosis are made mainly by genetic testing, and enzyme activity is not widely available. Treatments differ according to phenotype, as in other centers all around the world. We also would like to emphasize that initiatives should be promoted in order to spread the knowledge of disease, and cooperation between different centers and shared data should also be promoted, as well as the institution of reference centers for diagnosis and treatment. And finally, I would like to acknowledge Professor Cláudio Silva from Brazil, from the University of São Paulo, and Professor Ignacio Uriarte, who helped me a lot to perform this study. Thank you very much.